awesome.
You know, the other thing with health is that if I'm talking here, I may not see hands up there.
Okay,
And so then.
I'll whisper.
Whisper.
I'll whisper.
Sweet nothing.
Somebody's got their hand out at work.
And then you won't be
I would like to do this and I told you when I got something smart.
Hey, Paul.
Oh my God, it's in person. You look so different. Hi, Paul.
I know, I've shrunk an inch or so and expanded this way.
Oh, man.
That's right. We all saw each other like this, you know? Everybody, welcome on Zoom. We'll get started in a bit. And as we do, early on, I'll explain how this works and some of the implications. Edie, I see a thumb up. Oh, it's a thumb up. Okay. Eddie. I can't respond.
No, you just did. Yeah.
We have a lot to learn. How do you do, Laura?
Oh,
Here I am. I don't know, I like it, I like being online because I
I
can have
do
my tea, I can eat lunch. but
Yes.
Nobody's got it for my tea.
You know, I like the old way better. I'm old fashioned. How you doing, Bob?
I do too. I know for convenience, it isn't good, but I think for relationships, it is.
Yeah. I highly concur with that too.
Well, we got a fancy new speaker and mic, hopefully that'll work.
That's it. Not, if you speak, Paul, you'll go to the middle. Go ahead and say hello, how are
Hello, how's everybody?
you? You have to speak louder or more.
Does anybody hear me?
It's me, Laura Montano.
yeah, went straight to you.
Oh, thank you, Eddie. Okay. I know that the sound was an issue.
Jack.
Oh my God.
Jack, did you get a haircut?
I'm constantly getting them. What are you talking about?
I'm gonna let our meeting start a couple of minutes late because people may be finding parking places or trying to figure out how to get on. So let's wait another minute or two.
It's nice to see you here again, Kristen.
I think for the roll call and the login, we'll start here first and then go to Zoom. What do you think?
That makes sense.
I'll just call off everybody's name.
I mean, the way we usually do?
Yeah, I don't know how else can you do it?
You're right, Joe. Thank you. Thank you for correcting me.
April health board meeting we had in November. Okay.
Yeah.
I was like, I thought I grabbed the wrong minutes, but I didn't.
Just January, right? This is the month.
Yeah.
Okay,
Yeah, that's the month,
let's skip December.
although I thought it was February the other day.
It's coming fast.
It is.
Coming fast.
Mr. Chairman,
Yes.
if you'll look at the chat box there, you'll see number 2. That means 2 people were, left something in the chat box.
So Joe, you're the one who will click that, right?
Yes,
Because we can't do that.
there we go.
I ever am trying to fix my mic from Kristen, okay.
Did somebody got open? The chat?
Yeah,
Probably.
please do.
So Kristen, can you hear us? Just nod your head. Oh, no, you're in a picture. Yes, you can hear us.
Yeah, I'm missing the video, the being at home one.
We got Robert Ward now, so there. Okay.
14 up there.
We got a quorum.
We have a quorum, 1, 2, 3, 4, 5, and Tim Ash. And I thought I saw, yeah, Colleen.
You got the cartridge.
Oh, yes. She'll never forgive me if I don't remember. Well, everybody, I'm gonna call the meeting to order. And we'll go ahead with the roll call, and then after that, I want to make just some comments about how we're doing, how we're gonna work this. So let's do the roll call.
Melissa Norman,
Here.
Warren Montana,
Here.
Steve McGraw. Tim Ash,
Here.
Kim Doty,
Here.
Madison Flynn, Allison Tans, excused. Debbie Hartridge,
Here.
Colleen Broderick,
Here.
Danette Kellerman, Vernon Price,
Here.
Gardner Carlson. Here. Oscar McGowan.
So now's the time where we ask staff to introduce themselves. Why don't we start with the Zoom people? We'll start with you, Jack.
Okay, hi, everybody. My name is Jack Brazil, the Deputy Branch Director for Behavioral Health, and I'll word order to Jeremy.
Hi, everyone. I'm Jeremy Nilsson. I'm the Deputy Branch Director over Children's Behavioral Health. And let's see, I can pass it over to Kaylee.
Thanks, Jeremy. I'm Kaylee Emery. I'm the Quality Management Coordinator for QI for Behavioral Health and also fill the role of Behavioral Health Compliance Officer. And I'm here with my co-lead of our department to present today. So I'll hand it over to Elvira.
Thank you, Kaylee. My name is Elvira Schwartz, and I'm a program manager in QI. And yes, as Kaylee said, we co-lead that unit. And Oliver, how about you?
Hi, everybody. My name is Oliver Gonzalez. I'm the program manager for the Mental Health Services Act and Ethnic Services Manager for Behavioral Health. And I'll pass it on to Kristen.
Hi, everyone. Kristen Smith. I'm a senior health education specialist in suicide and violence prevention program over at Public Health's Healthy Communities Division. Thanks. I'll pass it over to Colleen.
Colleen's a board member. So we're looking to staff.
Sorry about that.
How about Sonia?
Thanks, Kaylee. Sonia Levy Boyd, I use she, her pronouns. I supervise the Humboldt County Transitioning Youth Collaboration and the peer coaches at the Transitioning Youth Division. Jack, did you go yet? I think you
Yeah, I went. How about you, Christine?
Okay, thank you.
Hi there, Christine Messenger. I'm with the DHHS Communications Group, and I'll pass it to Robert Ward.
Hi, Robert Ward, Housing and Assistance Coordinator with DHHS Admin, just here to listen in today.
All right, are there any staff members here in the room? We're gonna go to the room for staff members.
My name is Rhonda. I'm here to shoot at the Hope Center.
You got to speak up loud enough, okay?
Oh. My name is Rhonda. I'm here to shoot at the Hope Center.
I'm Laurel Johnson. I'm an analyst in DHHS admin. I'm Laura Coulter. I'm Administrative Secretary for Jack Brazil.
Joe McManus, Executive Secretary for Behavioral Health. Paul McMackey, Deputy Director of Behavioral Health.
We have introduced all of the staff members. I think we have. Then we go around and invite members of the public to introduce themselves. You don't have to give your full name, but we'd like to know who you are. Let's go right ahead. Let's start with you, Sharon.
Sharon Benda, I'm the NAMI board.
Anyone else that's on the Zoom?
I'll go real quick. I'm Eddie Morgan. I'm the Executive Director for Tri-County Independent Living. And my camera is not working for some reason, but I have the same haircut as Jack.
Thank you.
Very handsome man, I'm sure.
Most definitely. Yep, that's how we are.
Katie, you want to introduce yourself?
I will be happy to. Katie Wilson, local psychiatrist.
I think it's time for you, Edith, if you'd like to say hello and tell us who you are. You're muted, Edith.
Edith Fritchie, NAMI board member.
Thank you. Any other members of the public here in the room? Okay, I think we're ready to move on to the next item 3 on our agenda, and that's adjustments to the agenda. And I would request that the report from the chair be next, so I can talk a little bit about this hybrid meeting. Does that meet the approval of the board meetings? You can just say yes or hearing no.
Yes.
Sounds good.
All right, hearing no dissent. So everybody, this is the first time ever that we've done this hybrid report. And in the Zoom people, I will see you wave your hand. Please use the participants or reactions to raise your hand. So I can see that. So the other thing is, as much as possible, we continue to mute. So you know how that works, and that's what we want to do. What I want to talk about the people in the room is that the way this goes, you can see that I am there. If somebody else talks, this little camera here, you guys can't see this, will rotate to the person talking. If we have 3 people talking, it'll get very confused. Okay, so one person at a time talking. Steve Madrone, I see your hand.
Yes, apologies for my tardiness, but I am here and my camera's off because my signal is weak. Glad to be with you all.
Glad to have you with us. Thank you. We're going to work on chats. We have chats up on the right side of our screen. Can everybody on Zoom see the chats? Okay, that's working. All right. One of the things about this meeting is that first driving here, parking is a problem. Okay, you may have to park further away than you planned. And so I think you should put that into your considerations. It's a 2-hour parking period for the most part. So the executive committee is going to go and talk about this, and we may want to shorten the meeting by 15 minutes. I'm not going to make that decision, but that's something we're going to talk about. The other thing is that this building, the door is locked at noon to 1, but we have someone at the door. Maybe you can hear the doorbell sometimes, and they will quickly let you in. Other committees, this is the only place where we have, this is called an owl. Nobody can see what I'm pointing at. And so to have a hybrid meeting is not really possible if we want to do these things. So I'll make room for any other questions or comments. And I want to put this on the agenda from the executive so that you can see some of the decisions we're making. But are there questions or comments on this? Okay, hearing none, we'll go right on.
We've got a raised hand, Mr. Chairman.
Oh, Deborah.
Tim, I didn't understand what you said about we can't do a hybrid meeting, something.
They're using something in the center of this room called an owl.
Uh-huh.
It's connected to our computer that allows us to Zoom in a group, but we don't have the owl in other rooms.
Okay, thank you.
And Joe and I talked about that. We have a set time where we get this space, and a lot of other groups use this space. And so that's why it would be hard for other committees to try to grab this space. So that's where we are now. And I also want to say to everybody that the idea of this is, if I speak loudly, it should focus on me, but it's not doing that. It is?
It's just not close up.
It's not close up. Well, that's what I want.
It is working, Tim.
Oh,
It
there.
is working, Tim.
Okay, thank you.
It looks great, actually, Tim.
That was you, Sharon?
No, Katie Wilson, and on my screen, I can see a close-up of whoever's speaking, and then also an overview of the entire room, and it looks fantastic to me.
Great, thank you. So it's time now for public comments, and we do this as an opening to the public to participate in what we are doing, but it is a public comment. We ask you to focus on things that are under the jurisdiction of the behavioral health department. We want you to share in 3 minutes. We will not tolerate abusive, angry language. And so I'm going to invite you to start with your public comments. And it seems like all of our public is online, right? So I'm going to call out a name because I can see you. The next person would be Sharon. Do you have a public comment you'd like to share with us?
No, I'm interested in hearing what you have to say at the meeting, so.
Okay, thank you. Katie, I see you.
Do you mean me, Katie Wilson?
Yes, Katie Wilson.
I don't have anything specific because I brought up the agenda thing from November, and you already informed me how that's going to be handled. So I have nothing further. Thank you.
Any other members of the public? What I would like to do is briefly tell you that we got some online comments, and one was from Katie. It was large. It was sent out to everybody, and it's long, but it has serious questions and requests for the board and the department to respond to. This is available. We did send it out, and if you weren't able to get it, we'll be glad to send it to you. Sonia.
Hi, thank you. I know there was an open house for the AOT program. I believe it was yesterday, and some of our HCTC staff went and checked it out. And just wondering if there was any updates on how AOT was going in our community, and if there was any oversight on required or suggested trainings that the staff are going through, in particular training working specifically with transition age youth that might be recommended for AOT. So just wanted to ask that question generically.
Okay, Sonia, this is the time for public comment, and I want you to be able to bring that up at another time. And so I gave you a summary of the report from Katie Wilson, and that's not what I wanted to read. This is one from Beverly Steichen, if I understand it right. Yes, it is. It's rather lengthy, but she's reporting some trauma that she experienced in her family and wanting to present that as a comment to you all. Did I get them all? I think I did. So thank you, everybody. Let's move ahead and if everybody's all right at this time, Sonia, you want to repeat it or shall we just go with what you've already shared about the Mental Health Services Act and perhaps Oliver can respond to that. Oliver, did you hear?
I'm sorry, no, my speakers cut out. Can you say that one more time?
Yeah, I don't know if it's necessarily the Mental Health Services Act, but Laura's Law and the AOT program that's launching in Humboldt County, and just wondering how it's going, if there was any updates. There may not be a response during public comment for it, but also just asking if there was any oversight from DHHS on training that staff would be using to engage our community, specifically training tailored towards transition aid use.
Okay, thank you. We do have a regular agenda item on updates of AOT. And so Jack will make that later on in the program. You can ask him some more questions and he tells us what's going on with that. Let's move on to the agenda items. We have action items. One is to
Uh-oh, looks like we lost the room, huh?
That it
I'm
does.
here. I'm Katie Wilson. I'm here. And so isn't this weird? Is it that those of us online are connected, but not connected to the
They
room?
must have
maybe?
disconnected from the Zoom meeting somehow.
I'm just kind of satisfied that at least it wasn't just my little
Right.
sudden link failure. So I'm just going to hang tight.
It looks like Joe McManus is still logged in, but we lost the picture and we're not hearing them anymore. So I'm wondering what's going on there.
I'm just imagining somebody tripping over a cable or something.
Totally.
Yeah, and I'm wondering if they are aware.
Can someone call somebody there and see what's going on?
I can try.
Yeah, let me,
I don't know what
Laura's there. I'll get a hold of her.
Okay, thanks.
Thanks, Jack.
Owl flew off to get a mouse.
We're back online. Thank you very much.
Oh, good. We can't see you, but we can hear you, I believe.
Oh, you can't see us.
That's all right.
Yeah, I'm not sure if Joe is connected to the computer there, and then there's also the owl camera or whatever. It looks like that's what's lost, is your little circle camera.
There we go.
There we go.
There you are. What'd you do, Tim?
I just asked a question. I'm not in charge of that, Mr. Ash.
Can I make a motion to approve the minutes from 11:17?
I'd like to second that motion.
And 11:22.
Oh,
Let's do it-
21.
Let's do it one at a time. The first is the small meeting in which we said the recommendation.
Oh, I was there.
Approval of the minutes from 11:17.
There a second?
Yes, that was the second.
I seconded that.
Yep.
All in favor, say aye or raise your hand.
Aye.
Okay. Now the next minutes for the regular meeting.
Make a motion to approve the minutes from 11:21.
And I'd like to second that.
Oh, I see Debbie just seconded it. No, you didn't second it. Okay. Well, it has been seconded. All in favor, say aye or raise your hand.
Aye.
Okay, thank you, Jim. So I did want to say, and I forgot, when the roll call introduction of that Isabella Witherspoon has sent us her resignation and is no longer a member of the Behavioral Health Board. All right, so then we come to the approval to send the application for Catherine Smith to the Board of Supervisors for them to okay it. I don't see her here.
She will not be able to make it. I just texted her. She is working. She works in the ER. So today she Going to try.
Seems like a good thing. So why don't you go right ahead and introduce her to us, share a little bit about her. I was there at that interview, but you're the one who knows the most.
Okay. Catherine Smith works at St. Joe's in the ER. She was recommended by our former board member, Tracy. She's young, enthusiastic, and ready. I don't know, did everybody get her application?
And we should do that. Normally we count for the person to show up or.
Right, but we have sent them in the past. Tim and I interviewed her. She's excited to do good work in this field. She likes data and statistics, so that's why I like her.
Yeah, I'd like to say too, she has a lot of experience and I think will add a lot to the Behavioral Health Board. Any questions? Tim Ash, I see your hand up.
Yeah, I was just wondering if anybody has a copy, electronic copy of her application that they could put up on the screen.
Do we normally send that to everyone?
No, I just send it to the exec committee, and then it goes from there.
Okay,
I normally don't send those out there.
because we're the ones, okay. I don't know that we can, Tim Ash, will work on it, all right?
Okay.
Steve Madrone, I see your hand up.
Thanks, Chair. I've been recently been made more aware of the fact that our, what they call guidelines or bylaws actually require some percentage of our board to be actual consumers of behavioral health services. And another set of percents are supposed to be families with consumers. And those two groups are supposed to make up 50% of our board. Now, I totally get it. I mean, we were down to like half a board for a couple of years there. And I'm really grateful that we got back to a full board because I think that's really, really important. But I just wanted to remind ourselves that ultimately we do have these guidelines. But I guess if there were somebody, if we had a full board and it didn't include those percentages, I'm assuming that if a member of the public came forward that was a consumer of behavioral health services, that one of us would need to step down to make room for that person. Right now, I don't see that that's an issue because we're not being overwhelmed with applications. But I just wanted to remind ourselves, and perhaps Tim Doty or Ash can clarify if I'm accurate in that statement. Thank you.
I'll just say quickly, and I see some more hands up. Steve, we do that. We track that very closely. And when we provide a list of our members, they are listed as consumer, family consumer, like that. So the numbers, Joe, can you give us the breakdown of that?
I don't have that offhand. It's close to 50%.
I think it's at least 50%, he says. And so we'll try to make that available to you. We do send out the membership, and perhaps we can send out a membership later at that time. I see Tim Ash and then Vernon. Tim.
Yeah, I just wanted to say I agree. I think we're okay, and we do pay attention to that. The other area that I think that we also probably need to do a little better with, I know I brought it up a few times before, is to really work on keeping our ethnic and cultural diversity up on the board. Like Steve said, we had a heck of a time getting anybody, but I think once we get to like 13 people or so, we should be a little more careful, always trying to recruit folks that, fit into some of the underserved groups and minority groups. But once we get to that point, I think really rather than taking people on and then asking somebody to step down, I think at that point, we should probably say, we really are looking hard to find a person that's got a Native American background or African American, whatever we think we may be short of, or LGBTQ. And the TAY is another one that we've continually struggle with. But anyway, I think we should hold up a short, probably a couple before 15. And I think when I brought it up last, we said, well, we can go above 15, and that's also an option.
Thank you, Tim. Vernon?
We only have, I believe, 2 lived experience positions that are active on the board. Am I correct?
There's more than that.
I just found that I think we got 7.
7 lived experience?
7 family members.
Okay.
7 of each?
No,
Total
7
together.
out of the 13. 1, 2, 3, 4. Yeah, we have 7.
All right, we do have 7, and perhaps the executive committee can look into that some more. I see a hand from you, Oliver.
Yes, hi. I just wanted to give you a heads up. One of the stakeholder meetings that I did over in Eastern Humboldt at HUPA, there was actually one person that was really, they made it a suggestion and recommendation, actually, if they could join the board. Her name's Jennifer Lane, and she was actually the superintendent of their school district. And I just wanted to kind of find out what would be the best way for me to forward you their contact information, if that's something that is of interest.
So the best way to do that is connect with Joe McManus or have this person check with Joe. The application can be sent to her. She can send it back and we can set up an interview with you. Thank you, Oliver. Does that make sense? Oh, it is online as well, Oliver.
Okay, awesome. Thank you for letting me know.
Thank you.
You know, I would suggest just sending her a copy. You could do it, Oliver. Just send her a copy and let her think about it. And one thing that I would suggest is that you recommend that she attend a meeting or 2 and see if it's her cup of tea. And I wanted to back up on this, on the number. I didn't quite hear what was being said or in terms of the required constitution of the board. Where are we at in terms of family members and folks with lived experience with the illness?
It was 7.
7 of which, though?
7 total, but there's only 2 with lived experience that I know of.
There's probably more. One thing we have to think about when we do that is if someone's identifying as one and they fit both, then we need to talk about how to handle that. They may voluntarily move to help us with our composition because it's not uncommon for a person to have a diagnosis of a mental illness and be a family member.
Yeah, I know for a fact that many of us on the board have personal experiences and not all of us have disclosed those personal experiences.
Well, I'm
myself have, but there's there's you, there's me, we both disclosed, but there's many other people who haven't disclosed that I know
I'll say that
of.
there's 2 that have disclosed themselves with lived experience on our board.
Yeah. But other people are on the board as individuals with lived experiences. They just haven't disclosed it to the board at large. And so
Well, that for our stipulation to the state, we need to know who with lived experience and who's not.
I think Joe knows.
We have that. It's on the app.
Yeah.
Yes. Right, we don't advertise that.
But yeah, it's not advertised.
And I think that's okay. If we know we're okay, I think that's okay. People shouldn't be required to disclose something they are not comfortable disclosing. And if someone wants to take issue with it or someone wants to ask a question, say Steve, for example, we should be able to answer that question and just say, yes, we have 4.
Okay, I think at the executive committee, we should help kind of clarify this. I think we're all on the same page, but it may be questions about what a consumer means and a lived experience and what needs or we want to disclose. And I kind of want to move on. Is that okay if we take this up at the executive committee? Yep. So what we do have is an application. Appreciate all these comments. They're important. So I ask for a motion to approve Catherine Smith's name application to go to the Board of Supervisors.
I would like to make a motion to send Catherine Smith's application to the Board of Supervisors.
Well said. I'm gonna ask someone on the Zoom meeting. Would you like to second that? All right, Debbie and Colleen. Okay, we have a second and a third. All in favor, say aye or raise your hand or both. All right, motion is carried. So we're going to our time in the presentation, and the QI work plan is our presentation at this time. I'm going to hand it over to Paul. Paul, you wanted to start it off? I know you have some other people with you.
Yeah, I appreciate Kaylee and Elvira being on the.
It's really too quiet, sorry.
You better sit next to me, Paul.
Hopefully this will be a little bit better. Maybe I should have stayed at my desk. Maybe that would have worked better for me. But I'd like
It's
to
much
introduce,
better, thank you.
Kaylee Emery and Elvira Schwartz. They are our two managers in QI, and they put together our work plan as well as our work plan evaluations, both for our outpatient programs and also for sempervirens, in addition to all of the other work that QI is involved with. So this happens on an annual basis, and I think it's a good opportunity for the board and anyone interested is to learn about the work plans and to see what kind of improvement projects are the department's up to for the year. So I'd like to turn the time over to both of them.
Thank you, Paul, for the introduction. I appreciate it. And just to clarify, today we're just going to be focusing on the outpatient QI work plans in the context of EQRO. And if there's interest in the SV work plans, we could prepare to present on that in the future, potentially. I'm going to go ahead and share my screen, if that's okay, to share the PowerPoint presentation we created for today. So maybe you can let me know if you can all see the correct slide. For some reason, I always end up showing the wrong screen. So let me get myself situated here. Okay. Okay. Can you all see the PowerPoint presentation on the screen?
Yep.
Okay, great. Okay, cool. Alrighty, well, let's go ahead and get started. So as we did introduce ourselves at the beginning during roll call, but again, I'm Kaylee Emery, the Quality Management Coordinator for QI, and co-lead the unit with Elvira. Alyssa, it's so nice to see you. Hi. It's been a while.
I know. You're telling me all the stuff that I learned about, but you know, it's great to see you guys again. So thank you for being here.
Yeah, thank you for giving us the time to present today. So as I said, we'll be presenting on our QI work plan evaluation and our QI work plan that's currently live. And we're going to give you some context around the work plans associated with our external quality review, which happens on an annual basis. And so we'll just move through this PowerPoint together. What I did want to share was that we planned around 20 minutes for the presentation, and hopefully we still have enough time to take 20 minutes to present today. And what we were hoping to do is maybe we could allow for questions at the very end or along the way in the chat, and we could potentially just focus on kind of getting to those questions and answers during the Q&A section at the very end of the presentation, if that's all right. So Elvira, do you want to quickly just kind of reintroduce yourself before we move to slide 2?
Yeah, sure. Elvira Schwartz, co-lead in quality management. And thank you for having us today. And Kaylee and I have presented about our QI work plan before. And it's always a great opportunity to get the information out and to get some input and questions and have a lively discussion. So we are happy to be here. Thank you.
Thanks, Elvira. All righty. So moving forward, we wanted to give you an overview of what we were going to focus on for today's presentation. So we wanted to spend some time discussing the role and function of the California EQRO, or External Quality Review Organization review. We also wanted to spend some time over kind of overviewing the final report that we recently received from our November review. And then the bulk of the focus of our discussion is the work plans, because I think that that will be what interests this team, hopefully. We'll be able to share with you how we did on our work plan from the previous fiscal year, and share with you also where the goals have kind of taken shape as far as where we are currently. And then we'd like to wrap up our discussion to just let you all know what some of the recommendations were that came from our California EQRO review, which is part of that final report. Those often help guide the initiatives and goals that we work on within QI. And so then we will leave some room for question and answer at the end. All right.
Okay.
Thank you.
Okay, and thank you, Kaylee, for introducing CAEQRO. I know we are so filled with acronyms, and I will try and spell it out, as much as I remember. But so CAEQRO, California External Quality Review Organization, and so the California Department of Healthcare Services, DHCS, actually has a mandate to evaluate the specialty mental health services that behavioral health plans like ours are providing on behalf of the federal government. And so every year the external review organization, quality review organization, conducts a review of every county, literally, but Humboldt is a one-day review, and they're looking at the entire service delivery system, but from an angle and a lens of quality. And currently, the state of California is contracting with an organization that is called Behavioral Health Concepts, or BHC. So they serve as California's external quality review organization. And there is a review for specialty mental health services on the behavioral health side, but there's also a separate one for substance use disorder programs. But that's a separate review, and we're only focusing on behavioral health here today. Typically, the review team that comes to us, or in the last few years, it was always only virtual, but people used to come, of course, to do an on-site review. There's always a lead reviewer who is a very versed, experienced clinical person, mainly people who have worked in behavioral health plans in management, clinical positions. They have an information systems or data expert who joins the team, and there's always also a consumer and family member representative. And the way that works is there are breakout sessions throughout the day. And part of that, which is really important to emphasize here as well, is that there's always a consumer focus group. And that can be clients, adult clients. It can also be parents of youth and children in our system. So it varies every year. And then another important part is the direct services staff focus group or clinical line staff interview, so that our staff also gets an opportunity to talk to the reviewers and provide their feedback. And this year, we had a peer employee group that was requested, and that happened as well. And all of these focus groups and interviews make it into the final report as well. So Katie, next slide, please. Okay, so the focus for this quality review really has 4 components, and those are access to care, timeliness of care, quality of care, and information systems infrastructure. And just to give you some examples, what our review organization looks at in terms of access to care, they may look at service availability, also the capacity to meet beneficiary needs. That would be our staffing situation, but also the types of services that we are providing, and how we are coordinating care with partnering agencies such as our org providers or also the managed care plan partnership or beacon. An example for timeliness of care would be to look at how are we doing in terms of times that it takes from a non-urgent request to a first offered appointment for somebody. Also, how we're doing with emergency services or follow-up after psychiatric hospitalization. And then quality of care, they are looking at cultural competency. Our quality improvement plan, which we will talk about in a few minutes, is part of the quality aspect. They look at how we use data to inform decisions. Stakeholder input is a big one. And again, that is all stakeholders, program staff, line staff, consumers, family members, like everybody. They're looking at outcome measures, satisfaction surveys. In this case, it's more client satisfaction surveys in this context. Our consumer run program, the Hope Center, they typically really like touring that, but that was of course not possible since COVID. And also an area is consumer and family member employment. And then on the IS infrastructure, that is pretty wide and broad. It is not just how our electronic health record functions, but also how that ties in with claims data management. So the integrity of the claiming process, interoperability, how are we sharing protected health information, how that works. So those are the main components, and we get actually ratings on all of these. And this final report is also posted, and we have the link in this PowerPoint. We get ratings in terms of whether we meet something, a criterion, partially meet, or if we don't meet it. That's all in the report. Okay, Kaylee, the next one. Okay. So these 4 key components are not the only thing that they are looking at. So on this slide, there are a few other things as well. But first, I wanted to say that I actually just already said the final report is posted on the CAEQRO website. So that is not our own public facing website. It's literally the CAEQRO website. It's calEQRO.com, but the link is here on the slide. I'm hovering. Oh, of course, I can't hover over it because it's not me who has the PowerPoint open. Sorry about that. Okay, but in addition to those 4 key components, I just wanted to give you a very few examples of changes and initiatives, which is something, we send them a list every year, and our lists are really actually pretty long. So I'm just going to share just a few examples of changes and initiatives of the last year that are described in the report. A big one is, of course, everything that has to do with CalAIM changes, and CalAIM stands for California Advancing and Innovating Medical, which is really an initiative of many initiatives that included documentation reform, developing new screening tools, and the payment reform is still in the makings. So we had a lot of work around that. And another one was providing suicide 201 training, adding services in Northern Humboldt, McKinleyville Center, assisted outpatient treatment, which we saw was on the agenda today as well, but we were mentioning that because that launched last year. And so we also rolled out the racial and cultural equity plan, and crisis residential treatment facilities are in the planning and really advancing stages for both children and adults. So those are just some examples of changes and initiatives. And every year we get about 6 recommendations. And so fiscal year 21-22 recommendations, also just an example, we were asked to engage beneficiaries and stakeholders to review performance and measurement data, and also to inform our clinical and non-clinical performance improvement projects, which Kaylee is going to speak to in a minute. And another recommendation was to look at time from first request for non-urgent services to ongoing clinician assignment at the children's system of care, and also engaging line level staff and peer employees, basically to provide input in what they see as challenges and solutions to, you know, things we are facing as a system. So those are just a few examples. And Kaylee, you were going to just say
yeah, I can speak to
topics.
the PIPs.
Yeah.
So we have the requirement to have 2 PIPs, which is our performance improvement projects, going at all times. We typically split them between our children's program and our adults programs, where one is held within each system of care. And the intention is to have one that's focused on a clinical intervention and one that's focused on an administrative intervention. And just to kind of share where we're at currently, so you all have an idea of what that can look like. Our current administrative PIP is actually tied to some of the work that we're doing around CalAIM and improving a particular measure around our follow-up timeliness, following up post-emergency department discharges for folks who have admitted to the ED with a primary mental health diagnosis. And so we're looking to implement and expand how we're sharing data between us and our emergency department to better kind of flag our follow-up and use the electronic health record to help us do that. So that's one example of one of our current PIPs, and one that was actually discussed during our California EQRO review this last November. An example of our clinical PIP is, and we're currently kind of in the end data gathering phase of this one. It was held mostly by the children's team. We recognized a need for increased family therapy intervention to be used across our system. And so what we implemented was a 3-part series of training around family therapy use for our clinicians working with families, in the hopes that that will expand on our clinicians' comfortability in using that intervention and understanding of how to work with families better. So those are our PIPs currently, and just some information. I do want to note that I'm already, my PowerPoint app is telling me how long we've taken, and we've already used 15 minutes. We could probably use 2 hours today, but I do want to be mindful of the time that you all have set aside for us. And I know that the QI work plans will likely be something that you all want to focus on. So I'm hoping we can get through what you're hoping to hear in the time that we have.
Kathleen, we have the time and don't rush, okay?
Okay, thank you. That actually makes me feel a lot better. Thank you so much. Alvira, did you want to add anything on this this page before we move to the QI work plans?
No, I think no, I think we're ready, because we really did want to focus on the work plans and not so much on the actual review.
There's so much context to be provided with the multiple layers of what's involved here. And I think it's helpful for you to know the background. So thank you for letting us take extra time. Just to dive into what our QI work plans look like, and just to give you some context around the QI work plan as well that may have not already been addressed. The QI work plan really is a document that guides our continuous quality improvement process. I facilitate our 2 monthly CQI committee meetings. We have one for outpatient and one for inpatient. And then we have some additional meetings that really encompass and are a part of the general overall CQI process. That includes our cultural responsiveness committee, and then we have a committee on performance projects where we discuss PIPs, and then also something that's similar to a PIP for our inpatient unit, which is called an MCE, a medical care evaluation. And we've also had other branches to those meetings where we've wanted to dive more deeply into things such as taking a look at our key services utilizers. So we were taking a look at folks who were using more services in our system and sort of looking for patterns and areas of improvement in that. And so we have created a separate meeting that's part of our CQI process to dig into some of that as well. But to describe to you just what our QI work plan encompasses, we always ensure that our work plan focuses on these 7 areas listed on this slide here. And we're going to be looking at the evaluation of fiscal year 21-22 first. But the 7 areas that are always focused on is 24/7 access, consumer involvement, effectiveness of care, continuity of care, quality improvement, departmental training, and then utilization review, which really is kind of a nice summary of what we in QI focus on across the board and sort of support behavioral health with. So that kicks us off with something that we were really excited to update on this PowerPoint, because right before this meeting, I think just a day or two ago, we posted our final QI work plans to the to our Humboldt County Behavioral Health public facing website. So the link is here, and I'm assuming that we should be able to get this PowerPoint to you all so that you can easily click the links within the PowerPoint. But if you also look up behavioral health online, you should be able to get to us, and we have a QI page where those are stored. So it takes a little bit of time for those documents to get through the ADA process and be ready to be posted on our outward facing website. So we were really excited. It was quite timely that we ended up posting those just 2 days ago or so. So please, by all means, take a look at those. They are available, and we will spend a little bit of time talking about them today as well. So,
Kathleen? Oh.
yes.
Oh, Haley, I just want to say, go ahead and we can have the PowerPoint sent to all of the board members.
Oh, great.
Doug will just do that if you give him permission.
I will give him permission and I will send it his way. Cool. Thank you. All right, so we're going to focus on the evaluation first. So we're thinking back on the efforts that we did during the fiscal year of 21 to 22. So July 21 to the end of June 2022. And you can see here on this slide, you can see the highlights of what our goals focused on during that fiscal year. And actually, Elvira and I have kind of broken up which ones we wanted to speak to. And Elvira, I think you can go first because you've typically focused on area 1. So I'll let you go ahead.
Okay, so our first goal in Area 1 access was to implement video remote interpreting for American Sign Language. That was a goal in our work plan, which we didn't meet because there were contracting issues, but we have an alternative that we are pursuing now, and that is we have an existing contract with Language Line Services, and they actually also offer video remote interpreting for ASL and other languages. So that's a project we are pursuing now to just get it done through basically a different vendor that is already contracted with us, which hopefully will make this happen this year. And then the second goal in the Area 1, which is access, improve performance on the 24/7 toll-free access line test call metrics. So behavioral health has a 24/7 toll-free number that people of the community can call for a variety of reasons. I mean, that number can be used for crisis calls, but it's also designated for, for access. If somebody really needs services, not necessarily on an emergent basis, the expectation is that our staff answers those calls by providing accurate and comprehensive information. So that is something we monitor, and we do test calls out of QI. And there are like 3 groups of people really who are in the situation to answer that toll-free number during the day. It's mostly our front office people, and then we have an answering service after hours, and sometimes those calls get dispatched to the crisis staff at the crisis stabilization unit. So we train all 3 groups with scripts so they know what the expectations are. And this is an area that always needs improvement and pretty much carries over every year, because we need to get better at handling those calls. And area 2, Kaylee, hand it on to you.
Yeah, so I'm hearing myself. Maybe, I don't know, Elvira, would it be maybe helpful if you mute? Now I'm not hearing myself. Okay. Sorry, that distracts me a little too much. So for area 2, we always focus on consumer involvement in our general CQI processes, which is a really important goal area for us, because it's very crucial to include the voice of consumers and family members in the work that we do to improve our system of care. And so I will say, though, that some of the efforts that we had originally had, I think, some success with, sort of dropped because during COVID, we just weren't meeting in person anymore for most of those meetings, and we continue to meet virtually. And then also there were some meetings where Elvira and myself would attend, and it just became less of a viable option. So where our efforts have kind of taken focus have been to kind of catch up with where we are today in society around communicating and sort of living in this virtual world. And so we have been working really diligently to increase our ability to collect feedback from consumers and family members and so on in an electronic way, which we'll explain more, because that's really a kind of a current initiative and doesn't reflect on how well we did in this goal as much for the previous fiscal year. I will say that one thing that was notable in this area was that we did reach out to some local organizations, including Promotores and LatinoNet, and invited them to our cultural responsiveness committees. And from that initiative really drove a recommendation that came from our committee, where we made the recommendation to upper leadership around the creation of a possible new position. We were hoping to add a Spanish-speaking outreach coordinator. And so with that, I'll give area 3 over to Elvira.
Okay, thanks. Yeah, area 3 is effectiveness of care, and we have 2 goals there that are related to outcome measures or tracking outcomes of what we're doing. We have one such tool for adult services, and that tool is called the MORS, or Milestones of Recovery Scale, that tracks clients' progress towards recovery, where they are at, and their milestones is in the name. And on the children's side, we have the CANS, which stands for Child and Adolescents Needs and Strengths tool, which is a different type of tool, but used in our children's system of care. And our efforts in this fiscal year 21-22 work plan were more on tracking, well, what are the completion rates and what are our training rates? So those kinds of numbers. We're shifting, and I'm getting ahead a little bit because we're talking about our current plan as well. we are actually shifting from just counting, how are our training and completion rates to really how are we using these tools to inform treatment, which is, a different perspective and definitely of value. So, yep, that's about mores and cans.
Yeah,
And then
thanks,
we have
Elvira.
area 4 is yours.
Yeah, so area for continuity of care. One of the initiatives in 21-22 was to improve our caseload tracking and annual assessment and treatment plan timeliness. And those are really associated with some documentation standards that have actually since changed with CalAIM some, but when you really look at the heart of this goal, it really is quality focused, quality of care focused, because having up-to-date and current documentation in a client's medical record really helps the team working to provide treatment to have all of the information they need to continue to give quality services. And so it was an important goal for us. And what this entailed was making some updates to policies surrounding who we sort of hold as the case carrier and who's responsible for the upkeep of documentation surrounding their particular cases. And some of those efforts happened sort of late in the fiscal year, so we didn't necessarily see a huge shift in improved caseload tracking from a statistical standpoint, but I will be kind of happy to see how that shifts over time since we've given it some more time with this more clarity. So that will be interesting to see how it moves and shakes out as we continue forward. I'm going to go to the next page where we can wrap up the rest of the areas for the evaluation, and then we'll spend some time on the new work plan as well. Elvira, are you? Oh, I'm going first this time. So area 5, quality improvement. We had two.
I just wanted to interrupt, wondering how much more time in your report so we can get to questions and comments.
I'm sorry, what was that?
How much more time do you think you'll have in the presentation? Have enough time for questions?
I think we could probably go maybe 6 or 7 more minutes. Does that sound okay to this group?
Yes.
Okay, and then we can leave time for, okay. So I'll try to brush over things in a little less detail, which might lead to more questions, but hopefully not. So for quality improvement, we were working to build upon sustainability efforts and work to increase overall capture of direct services. And we were also looking to improve upon our policy and procedure tracking and training. So the sustainability effort has been sort of an effort that's been carried by management for some time, and really just working to ensure that folks who are providing direct services are accurately capturing those direct services in the way that they code and bill and document. And so we actually found that there were a lot of times where people would kind of self-disallow just to make sure that they weren't inaccurately claiming. And actually one of the shifts in CalAIM has really been an opening up of the ability to capture billing for direct services. And so that will also be something that will be interesting to track over time. We improved upon our policy and procedures tracking and training by implementing, we've had I think a really solid tracking process for some time, but we kind of increased our work around this by creating a desk guide that was used by those who are responsible for the upkeep of policies. And I can report that we've done a really great job, particularly in some areas where there are a lot of policies and procedures, to really get caught up on our every 3 years review timeline. I'll hand number 6 over to Elvira, and then I can quickly touch on 7.
Okay. So area 6 is department training, and our first goal there was to increase the completion rates for onboarding checklists for newly hired staff. And so what we did is there was actually an onboarding checklist and onboarding process created by DHHS overarching a few years ago, and that had the option of, you know, tailoring it to departments. So we created or tagged onto that and created our own onboarding checklist. And the significance for this is really, if you are onboarding new people, you really want to do it right, and you want to train them well so that they stay. So this goal really has to do with staff retention and the importance of taking the time, investing in that process, and making it as best as we can. And so our goal was to increase the rates of just completing the onboarding checklist, which we realized that is really different from how onboarding actually happens, because the numbers were not so great. 54% of, you know, just the formal aspect of it, getting these checklists back to QI for tracking, which is not necessarily what happens on the ground in actual onboarding. So sometimes as we go about our goals, we realize, well, you know, we should look at something else or reword them, which we do. It continuous. That's why it's called continuous quality improvement, because we learn as we go, also reframing our goals when necessary. And the second goal in Area 6 department training has to do with a number of trainings that are actually mandatory. So some trainings are really mandatory, and examples for that is an annual compliance training, cultural competence training, and clinical documentation training. And we have, luckily, many methods to conduct trainings, but something we rely on heavily is our learning management system, Relias, in behavioral health, but also NeoGov at the DHHS level. And so we kind of like integrate those. We had really good compliance rates for the cultural competence training. Those were at 91%, and compliance was also pretty good at 73%. The clinical documentation training, we actually shifted how to do that mid-fiscal year. So we literally could not actually track that goal to completion just because of the shift to CalAIM documentation redesign. We had to stop our you know, regular documentation training and shift to the CalMesa, the organization who helps with the implementation. And so we just couldn't really have a consistent way of tracking that. It was a shift in the way we perform those trainings. So that's what happened with those trainings. And yes, Kaylee, Area 7.
Yeah, and then we've been working for some time to reintroduce a doctor-to-doctor peer chart review process, and one was created and actually pretty well trained to in year 21-22. I will just note that this continues forward to be a goal currently, because we found it quite difficult to implement without a medical director currently. And so we do kind of, I think we've established that we need to move forward without and sort of do what we can. So that one will continue forward. And that actually shifts us to something that I think we'll go through more quickly, just because these are our current goals. So we won't necessarily reflect on what we've done, but what we're kind of doing. And we've already touched on some of this, but Elvira, do you want to kick us off with Area 1?
Yes, Area 1. So that's the same goal as last year's plan: improve performance on the 24/7 toll-free access line test call metrics. So again, the way our staff are handling calls that request access to services is an ongoing goal, where we will review our scripts and training approaches and hopefully make some changes that makes things better.
And again, our goal continues forward. I think I've really addressed what we're currently working to do, which is to really expand on catching up with where we're at societally, and making sure that we are using tools to be able to gather more input in a more diverse way. And so we have already and are continuing to work to get a lot of the paper forms that are submitted that elicit feedback back virtually. And so we've created a QR code which can be scanned at provider sites to be used for client comment feedback cards. And we're working to make that more user-friendly. And we're also working to get that more expansively used for things like submitting a client concern grievance or filling out surveys. And so we hope that that will end up being really successful, because I think also it helps to eliminate any pressures that might be felt when going to fill out something like that. Particularly a grievance or concern can be kind of nerve-wracking to grab the form if you're near your provider. And so I think a more quiet way of being able to do that is really important. So that's some of the work we're doing currently. Let's see, are you up next, Elvira?
Yes.
Okay.
Yes. So in area 3, effectiveness of care, we actually added one goal and are carrying 2 over. So the first one there is the use of the milestones of recovery scale as our outcome measure. We are definitely still pursuing that with more of a focus of, how can it inform services to lift people up on their road to on their recovery journey. And but there is also some criticism that has come up around the use of that scale at large. And so we are at the same time also looking at possibly implementing a different outcome tool that may replace the MORE. So that's another goal for this year, to just research other measures and decide on one that may serve us better for the adult system of care, that is. And then for CANS, the children's scale, we and I already said that we're looking at that more from a lens of clinical decision making, and also using it to inform treatment rather than just looking at completion rates. Yep.
And so with some of the shifts in CalAIM, which was described previously, there's been some expansion as far as how folks can access our system of care and the managed care plan system of care, so specialty and non-specialty mental health. And some of those initiatives include things like no wrong door, meaning that you can really begin to receive services in either system of care with Partnership Beacon or within our system, depending on your need, and allows for time for assessment and kind of a thorough decision to be made as far as where someone is kind of fits best for their needs to be met. And so in that, we really identified that there's a need for improved coordination between us and the managed care plan. And some of those efforts include the rollout that we're currently sort of actively in the midst of, which is rolling out a screening and transition tool that is standardized across the state, which will be used as a referral mechanism with Partnership as well. And then let's see, for area 5, we're continuing to build on the sustainability efforts we talked about on the previous work plan. Some of what we've identified is just the need for for staff who are using the dashboards that we've created out of QI. Just some training efforts could really help support how they're using those reports to work with staff and work within their program to make programmatic decisions. One that I'm really excited to announce to this group, and kind of happy to see that Kristen is here as well, since we've been doing some collaboration with Kristen over at Public Health around this initiative. In area 5, we have goal number 2, which is a new one, our suicide prevention initiative. And we've recently identified some funding sources to be able to pull in a couple of consultants who really specialize in suicide prevention efforts. We've identified some areas of growth need for us in our system around some of our various kind of exploration and case dives around deaths that are the result of suicide or homicide for people who have had a behavioral health encounter recently. And we're actively involved in the suicide fatality review team as well, which is facilitated by public health. And in that, we've really identified the need for a standardized assessment or screening tool and around suicide risk and some other various elements. And so I'm very excited to be moving that one through. It's probably my favorite one on the list. And with that, I'll hand over area 6 to Elvira.
Okay, so area 6 has to do with a new outpatient documentation training to reflect the CalAIM changes that we talked about earlier. And what that really entails is that the new documentation training is now provided online in multiple modules through CalMesa Mental Health Service Administration. But there's also a need to have it a little bit more localized, you know, how it ties into our specific electronic health record. So there's actually a companion guide that our unit has been working on that I believe it has not been released yet, but we definitely have to do more than just rely on the trainings that CalMesa makes available. So that's the goal around documentation training. And then another really, really exciting thing is to develop a Lantham and Patris Short Act manual. So one of our training clinicians has taken, you know, the lead on that and came up with a very comprehensive manual. We had something very, very outdated, and there are a lot of regulation changes about psychiatric holds. So all of that, we wanted it at the fingertips of the people who need it as a reference, a comprehensive reference document. It's in the review stages, but we'll release it hopefully soon. Okay, last
and
one.
I've already, I think, addressed this one, so we can move forward. We just continue to move the work forward around the last area goal. Okay. And then I want to be really mindful of questions and answers, so we may need to move through this last slide rather quickly, but Elvira, maybe I'll let you touch on it.
Totally quickly. This is our last slide really of the presentation, and we wanted to tie back our you know, the information we provided around our QA work plan back to the EQRO review at large, because what you see on these slides are our new recommendations that came out of the final report. And addressing these recommendations, they are not necessarily part of the QI work plan, so that's extra, but this last slide just kind of like ties back to how we started out the context of the California External Review Quality Review Organization. So we have a recommendation to aggregate CANS data. HEDIS measures is something we haven't touched on. Those are the healthcare effectiveness data and information sets. There was a recommendation to look at those. And I have prepared some examples, but I'm going to skip that. Another identified recommendation was training peer staff and ensure that peer staff have completed job-specific training like crisis intervention, case management, ethics, learning what is a peer parent partner. And I do want to say this, though, very briefly. Some of these recommendations, when we read them, they come straight out of focus groups, but it also makes us think, you know, where are gaps? Because we certainly have a really, really good training program that is available to peers. So we just need to kind of like make sure that it's broadly applied and maybe a little bit more structured. But sometimes the recommendations read as though nothing is in place. Another recommendation was to engage families in a committee to create a family-friendly environment within the youth and family clinics, and that is at the plaza. So that came out of a focus group, and then an employee satisfaction survey. So that is a really really great endeavor that we have already started to express challenges and solutions within the mental health plan. So there will be a staff satisfaction survey coming this year. And the last one is a timeliness related recommendation to accurately track urgent service requests. So tracking basically for emergency services. And that's it.
Yeah, and perfect timing. I see that Katie Wilson has her hand raised, and this takes us right into Q&A. Did you want to ask your?
Kaylee, this is your role now to direct questions and answers and.
Sure.
But I want to say continually, we need to keep it to a 3-minute.
Okay.
Also allow one time so that other people can participate. Does that make sense?
Yeah, I think so. Cut in if I don't get it right. But I saw Katie Wilson's hand up first.
Well, thank you, but I actually didn't intend to go first since I'm not a board member. So I actually have quite a few questions, and I was even thinking I would write them down and send them to you guys and the board. But after anyone else asks their questions, if there's no other questions, I could ask a few of mine.
Okay, and just to state, if we don't feel like we have time to address them here, please feel free to jot down this email address or this phone number to be able to reach out to us outside of this meeting as well.
That's great.
Thank you, Katie. It is primarily a time for board members, but I'll try to make room at the end for the public, okay?
Okay, I'm not sure who our board member, well, I guess Tim Ash, do you want to go next?
Steve Madrone had his hand up first.
Oh, Steve Madrone, please.
Thank you very much. First of all, great presentation. Appreciate all of the detail. But I have to say my head's swimming a bit, right? Because it's so much information. And I guess what I was looking for was, well, how are we doing? Right? I understand the goals, and there were a number of comments throughout the presentation of, oh, we heard we need to do better at this or that. But I mean, for me, and I suspect for most of the board, but I don't speak for them, it would be really nice to have a matrix that says, here's the things that we need to do, here's how we're doing, and here's our plan to get the others done. I mean, just some sort of way to really wrap my head around how are we actually doing with these things? Because just telling me what your goals are and the rest of it doesn't tell me how we're doing, right? So that would be my primary input. And I appreciate the opportunity to hear all this information. I learned a lot. Thank you.
Thank you for that. I completely agree that it's kind of a lot to digest in one sitting. And I think we attempted to try to get at how we did during 21-22, and it probably blended into how that carried forward and sounded more like more creation of goals. I will highlight that if you are able to access this PowerPoint afterwards, and you can use those links to look further into the documents, the evaluation and the work plan and the EQRO final report will really, I think, help with that. And I apologize that we didn't get enough to that point. I can see why you're highlighting that.
Katie, I'm going to jump in. Can you remove your PowerPoint so we can see each other?
Yeah.
Thank you.
Totally. Okay. Who should go next? Tim?
Why don't I lead that and you can do the answers?
Okay.
I see Tim Ash and then Debbie Hartridge. So Tim Ash?
Hey, one brief comment. Katie was going to submit some questions. I think the most beneficial thing would be to make sure that the answer to those questions, that it goes to the entire group, everybody that's involved.
Sure.
But anyway, that was just a small thing. But the other question that I had, and it kind of follows along the same trail that Steve Madrone was talking about. You know, I look at the MHSA, you know, the 3-year plan proposal, and they talk a little bit about different programs. It's not always emphasis on penetration rates, but I see that a lot. And to me, that's useful, but it's limited because you know, if you say, well, this program encountered 200 people last year, what I want to know, and I saw that you're talking about this as part of your work plan, but I want to know, well, how many were helped? And it's kind of what Steve was saying, but it's a little different. You use mores and use cans. And I guess one of my questions, I would just like to have us looking for something that tells us really how is this working, both cost effectiveness and how many people are really benefiting by these programs. But I guess the final comment to that would be, I was going to ask this, it sounds like you're going that direction, is we're using mores and cans and we have for a long time, and we've always said, well, this is what it tells us. But we've never really heard a discussion about what else is out there. What's the best practices in terms of measuring outcomes, in terms that are useful, what's out there, and then how do we decide what we're going to do? Because most organizations have certain inertia to change. And that's my concern, is it'd be nice to know if there's something really good out there. Great, not necessarily something just change for change's sake, but what are other people doing? And I saw you look at that. So thank you.
Thank you for all that. I actually was a couple of things came to mind as you were speaking, Tim. And one thing I'm really excited about, which likely has been brought up to this group before, is that we are shifting to a new electronic health record come July. And what I'm really excited about in that is that it's collaborative with Cal Mesa and other counties. And there's a real hope to make the EHR sort of help us
Not an easy job.
reflect.
Wait a minute, who's talking? One person at a time.
Maybe somebody's not muted.
Right. Gotcha.
Steve Madrone, you're not on mute.
Sorry about that.
That's okay. So I was just speaking to that we're hoping to use a lot of data points that will be accessible already in the electronic health record to really help inform that very question of how are we doing, and more specific outcomes. And then we, of course, are also looking into other outcome measures. One that comes to mind that we've spent some time researching, it's called the locus, and I can't speak specifically to how well that one suits our needs, but I do know we're exploring with other communities what they're doing, and you know, what is best practice and outcomes, and really just becoming a more data informed agency is kind of at the heart of what we're doing. And I imagine that if we would have shown more data, it would have been helpful today, but we sort of gave the overview. But I will tell you, we're looking at these key indicators that you're wondering about, and we are looking at trends over time. And we did kind of probably speak to it a little too high level today, but thank you. Elvira, do you have anything to add to that?
No, just that both reports, the final EQRO report and the QI work plan evaluation and the current one, they are posted. That might also be a good, you know, if you wanted to dive deeper into that, just look at those and then send us questions. But there's a lot of, you know, numerical data on how we are doing in all three of the, well, the two reports. The new QI work plan doesn't have any data yet, but the evaluation and the final EQRO report. And I also do want to take this feedback to heart to maybe next year when we come, I don't know, maybe select some areas, not go over everything, but select some areas and go more into details. I guess that's one of my takeaways here.
And Elvira, there's a couple private chats I'm having in the chat that have to do with just wanting to see dashboards, and so maybe bringing some of those here. And,
oh yeah, we don't
showing
we
the data.
Plenty. We have plenty. Okay, good. Thanks.
Okay, I want to keep moving on. Debbie and then Alyssa.
Thanks, Tim. And I really just want to echo what Steve Madrone and Tim Ash said. And for example, I just read a report about the Arcata Community Ambassadors Program, very brief report. And it was very powerful to me as a member of the community, a taxpayer, you know, a supporter of all these good works. But it just said things like, for example, that new program, the Arcata Ambassadors, I won't go into the time period. There's some time period they were watching, and there's been, because of that program, they believe they can claim 65% reduction in verbal disturbances. And this is a program where the ambassadors, and Laura Montagna is one, go around and you know, talk to people on the street. And so they're seeing this reduction in verbal disturbances, in drunk in public calls, municipal code violations. I mean, it's real stuff. And it's helpful to have that kind of data for those of us who are out in the community talking to people about what mental health is accomplishing. So that's my, and the other thing I noticed was one other thing was there was one of the recommendations had to do with parent input. And it looked like it was just for kids, just parents of young people, minors. And so I would say don't neglect the parents of adult children too, because there are a lot of, as a NAMI member, we know lots of parents who are very helpful to their children and can be allies in treatment and so forth. So do include parents of adults too. Thank you.
Thank you for that. I will note that that's the way the EQRO focus groups are focused, but when we do focus groups within QI, which we do have a plan to do this year, we actually have typically focused on adult family members and you know, important people in our consumers' lives that are adults and also children. So just wanted to echo that we feel the same, that it's really important to involve family members kind of across the lifespan and not just when youth are accessing services. Thank you. And I want to read that report that you were talking about. It sounds helpful to kind of structure what we do. Thanks.
Well, it's very brief, but you know, sometimes brief focused things are more powerful and generally useful than more detail can be sometimes.
Agreed.
Okay, thank you. We have a hand up in here for Alyssa.
Alyssa.
Hi. So I remember back when, you know, I was doing an internship and you guys were just starting to teach me the ropes. Thank you, Elvira. It was incredible. You taught me about the Moors and how how recovery was being implemented and how the culture was changing and how peer individuals were being more included into DHHS, and how the Moors was being used as a major a measure of outcome for a recovery-based peer outcomes. Anyways, what I'm wondering is, back then, and people weren't really following along very much with the Moors, and now you're talking about the Moors, and is it even being used nowadays? And also you mentioned about Moors criticism, and so that makes me really curious. And then you mentioned other evaluations like locus, and I don't know if HEDIS or HEDIS is one of those evaluations, but it's just like, okay, so what's going on? So that's one question. And then the other one was the peer employee group that you had reviews for the Cal EQRO. I wanted to know what they said to Cal EQRO. I'm really curious about that. Okay, thank you very much for the presentation, guys.
Elvira, do you want to answer Alyssa's questions? They sound more kind of in your realm. Thanks, Alyssa.
Yeah, definitely about the Moors, Alyssa. And, you know, that's kind of hard to answer for me in a nutshell, especially since I'm a very enthusiastic supporter of the Moors just because it is a recovery-based tool, unlike others. But some of the criticism is something that, oh, you have to assign a Moore score after pretty much every single interaction with the client, which people find cumbersome, as opposed to like the answer, which would be the adult's equivalent of the CANS, which would only happen in intervals, the beginning of treatment, maybe after 6 months or after a year. So it is something that doesn't happen as often. So that is one of the criticisms. Another one that I'm aware of is that the Moors is all about, you know, really lifting people up and out of our system of care into the community and lower levels of care. And our average Moore score across the board is a milestone of 5, which really means people are actually doing quite well. They are sustaining they don't have too many disturbing incidents or episodes in their lives, but they also cannot be on their own. They cannot, without the help of the service delivery system or behavioral health services, be out and on their own and pursue their own goals, because they need that help. And to lift them where community supports, family support become more important to them, you know, to lead the lives they want to live with less involvement of staff. And so I have heard staff say they are really, really frustrated because they don't know how to get somebody there because there's a lack of resources, or some people just don't want to get there. So those are criticisms that I am aware of. Another one is, and that I have literally researched this with other counties, and some counties are telling me, well, it's just like staff have so much on their plates to do. It's another piece of paperwork, and, you know, to complete an outcome tool. But that's also where our pitch for it comes in, to really show, as you know, people who train to these tools, what they can be used for, and how, you know, how they can be of value when treating people. And I know there are tools out there that have actually algorithms attached to them. Some are tied into electronic health records. So there are things that might be better suited, even though I'm still a big Moores fan. And Alyssa, what was the second question that you had?
By the way, thank you very much. The second part of the Moores question is, what are we going to do if not for Moores? Like, how are we going to judge recovery outcomes?
For right now, we're continuing to use it, but with the perspective of replacing it with a different tool.
Okay, and then the other question I had was, when the Cal EQRO came through and included the peer employee group review,
yeah,
I was curious about what the peer group said about DHHS during the peer group review.
Well, we don't find out what is discussed in those groups. That's between the reviewer and the people who attend. So what we know is, just based on the recommendation that was formulated in the final report, is that peers expressed that they do not feel well trained, even about their role as peer employee, and then training across the board, like everything was mentioned in this recommendation. So that's what came out of those interviews and focus groups. And again, I said, well, from our perspective, we have a number of trainings in place, also supervision. I mean, our peer employees receive regular supervision just like any other staff. And so we'll have to, find a way to train maybe in a more formalized way, but we'll address that recommendation. But Alyssa, no, we do not know exactly what was being said in those groups. They don't tell us.
process. Thank you so much, Elvira. I've been hanging out with the Hope Center again lately, and I would love to be able to see for them to blossom and bloom and see the peer program really expand. So I eagerly await. Thank you.
I just want to move us along. I see Colleen's hand up, but Joe, can we get rid of the chat so that we all, you know, we don't have that on the screen, but we can see each other better. When the chat comes up, we can bring it up there.
It's
Until you forget the chat button. Okay, then can we expand the screen there, the big box in the middle up there in the top right-hand corner? This is all just technical stuff.
So somebody else has a question?
Yeah, but I wanted to make the screen work. Yeah. Thank you very much. Colleen.
You know, I, as a provider who's been on the other side of the desk, I can tell you that I have real problems with sometimes the way we look at tools, evaluation tools. Number one, you have someone sitting across the desk who is desperately symptomatic, requires help. You open your electronic record and it won't even let you get to documentation until you complete test A1, 2, and 3. And if you ignore those things, the next month you're going to get a report from your supervisor that says you have failed to complete test 1, 2, and 3, all existing outside of the knowledge that this patient is critical and this client needs help, that you are actually bound by protocol to start in asking questions that aren't relative to their situation at that moment. So I'm not being critical of QI at all. I deeply endorse it. I also want to tell you that sometimes the expectations on the other side of the desk as a provider are very difficult to meet those kinds of anticipations. So I just wanted to throw that in. Thank you for listening. And I really did appreciate the presentation.
Thank you for that. We really try to embed ourselves in all of our programs so that we really are getting input from direct service providers around all of this because, and I was a direct service provider myself, and I'm a licensed marriage and family therapist, so I can speak to some of the similar experiences. And it's really important, I think, for us as we take charge and move directions, if that's what's best, to really include the voice of the stakeholders who are our providers as well. Thank you for adding that. It's very helpful.
Thank you. Did you want to raise your hand?
I did. Just a quick question. Has there not been a staff satisfaction survey before? Yes or no?
Yes, there has been. Two.
In the past there have? Okay.
But it's been a long time.
Okay.
Yeah, and we tailored this one that we're working toward is really tailored toward things like retention and well-being in the workplace, and it kind of came directly from some of that stuff that has been lifted up. Yeah, good stuff.
All right, thank you. Then I would like to make a comment. I want to continue Steve's and Tim Ash's and Debbie's comments in that we want to know how things are working. And it seems to me what your job is to analyze the metrics and to find that kind of quantifiable way, like how long does it take to answer the phone? Okay, for instance, we want to know how well that went. If somebody called and said, I got a big problem here, and not simply how long did it take you to answer that phone. And I know that's hard, and I've been involved, and Elvira will know that I've been involved, and she knows how much I love her and how smart she is. But so, and I guess the other thing that might be involved in this is that you provide analytical metrics and not comments on so much on what actually is going on, so that when we make comments we may be sending them to the wrong person. Because someone else is involved with the program, but you provide the analytic metrics. And I've been involved in some of those conversations. So do I understand that correctly?
I think you do. We are looking at analytical context to these things, and like we already addressed, it probably would have been better to like sort of hone in on a few things and bring that here. And I would say that that's just a portion of what we do, and a very big one. And there's a lot to QI, but definitely looking at the metrics tied to these goals is part of what we're talking about today. So
yeah, and to add to that, I mean, we are not only analyzing the metrics, we are also the ones who create what those metrics are. To some extent, some are given to us, like with these test calls reports, that we get the metrics straight from the state, and that is the case for others as well. But for a lot of them, we set our own goals, so there is some leeway for us there. And I think a really good example is actually what we said, not just look at training completion rates, because that doesn't say everything. It doesn't cover everything, how things are actually going. So to add to that, what are the effects of training? What did people do with the training? Even if only 60% completed the training, what did that actually look like or translate into actions? And so we do have, that flexibility, and I would say it's required of us as QI, to continuously change what we're looking at based on feedback like this.
Yeah, I want to say, I kind of understand that. Our questions often do, how does this training work? What's the quality? What's the outcome? Those are hard things to measure. But if somebody says they've been trained in dialectical behavioral therapy, I kind of want to know that training, because I follow that kind of stuff. If you have a one-day class on it, you're not trained. And I guess along with that, if I were to suggest some metrics for us, it would be to provide us the experience for every staff person who's related in this service. You just need to say name, they've been trained in this, that, or another, educational formats like that. And also, I guess, I would say another metric, and working with some parent partners over the last couple of years, they encounter traumatic instances that go on. And I worked with Arcata House, and I say, if somebody has a psychotic break when you're visiting them, how do you handle it? Are you skilled enough? Do you have a supervisor, like an LCSW could say, oh, this is what a paranoia schizophrenia, a stigma or a trigger is, and how you respond. And also, I know it's hard for you. And so when I was talking to some, is there a support group? Do you have a mental health person to help you process that, to feel like you're being heard? And it seems to me that the retention of staff and the quality of their work will be vastly improved if they can do something at a higher level than just a group of people talking about how things went. I don't mean to be taking all this time, but I guess I do, and I'll stop it at that. And perhaps the Behavioral Health Board can explore more ways to get these kind of questions. And I have some thoughts, but I think we're running out of time.
Can I make one comment?
Yeah.
Just to end this presentation, thank you, Kaylee and Elvira, for this. I think if there's 3 documents for the Behavioral Health Board to really pay attention to on a yearly basis, it is the EQRO report, because that's a real good drill down on it, that has matrix, that has data, that does show really how well the behavioral health plan is doing or not doing, and comes up with recommendations. The work plans and then their reviews, because that again shows you really specifically areas of focus that are doing well and not doing well. And then the MHSA 3-year plan. I think when you look at all 3 of those regularly, that's really going to give you a finger on the pulse of behavioral health. And I think because what you'll find in there are these specific matrix that do tell you kind of how we're doing across the system and around the state. How do we compare with other counties, for instance? So like a 7 and 30-day readmission to sempervirens, for instance, that is a standardized measurement of how well that service was. If people aren't quickly cycling through all the time, if they have a long stint in between episodes, that's a good sign that the service was good. I rate the other one too, the timeliness part. That's another good example in there. That's in those reports.
Yeah, we can have that discussion. I think the 4 or 5 of us are wanting other things to look at in that. And so we're running out of time. I want to thank you, Katie.
Thank you.
I'm sorry we don't have any time for you now. Thank you for the presentation and everybody's involvement. Hopefully it's been a good learning experience for everyone. Thank you. Thank you.
What could we hear from Katie? See what she had to say, if it's a long or shorter comment?
Tim, actually, we have 10 minutes to finish everything else on the agenda. Is that all right?
Yeah, we don't have time.
We don't have time. So we have no reports from the DHS director nor the behavioral health director because they are not here unless another deputy director has something.
I was just asked to answer some questions about the crisis triage center. If now's that time that you'd like to hear about that.
It's really important and big and covers a lot. Why don't you just say to us briefly, we read it in the newspaper, that's what we know, briefly how it's going and what it'll do.
Well, it's going good. We're working with Mad River. We're working with Cal Poly Humboldt and an internal group in Dr. Bryan and Waterfront. We're applying for some grant funds for round 5 funding. There's about $15 million for our region, Humboldt County and some other rural counties to apply for some construction money to build a crisis or to expand out the crisis continuum. So we know that we have a need for increased capacity there, both an inpatient unit as well as more other crisis focus like the crisis stabilization and other SUD treatment types of beds. So we're focusing in on that front end with this proposal. So we'll have a sobering center, we'll have an expanded crisis stabilization unit that can serve both children and adults. We'll have some crisis residential beds as well, mental health on the mental health side, as well as some on the drug SUD side. So that's going to really help with log jamming that seems to be happening at EDs and allow for folks to be triaged to the appropriate level of care here in our county.
That is really awesome, Lisa. Most of it say that's a great step forward. And I'd like to see maybe an ongoing agenda item like we do with AOT or something like that, where we can, and I know it's just the early stages, but you're making plans for these things. And thank you, thank you. So anybody else speaking for a deputy director from ME? Okay, or Connie? So AOT update, Jack, can you do it in 90 seconds?
Sure. AOT is again, up and running and moving along. And Sonia, I know that you had asked a similar kind of question before, so I apologize. I feel like maybe I missed getting back with you on that, but feel free to email me to any questions you have about it or things that you're thinking about. But it is up and running. We have about 8 participants now.
Wow.
In AOT. Again, none of them have gone through that court-ordered process yet because most of them seem to be willing to engage with EA, voluntarily. So we've just been, really patient with that. We are hoping to provide some outcome measures here pretty quickly that we'll be happy to share with the board. We're going to be going to the Board of Supervisors to hopefully we will do this and present that information there. So, we'll have some numbers and things to share with the board Behavioral Health Board and Board of Supervisors very soon, we hope.
That's great, Jack. Looking forward to it. Maybe we'll give you some more time at the next meeting and after you talk to the Board of Sups. Any of the committees have something urgent they want to share at this time? Okay. Chair, Vice Chair? Not much time.
Yeah, I will respectfully pass.
I have went to the Hope Center yesterday, participated in their community meeting. It was wonderful to be able to see what's going on there. I have plans of attending more often. It's a great environment and they're doing a really good job there. And yeah, that's it.
Thank you. Thank you. I would like to see us put it up on an agenda item in the near future because we have some openings for that. I don't think we have the next month's agenda item.
Okay, yeah, Hope Center.
All right, my clock says we have 5 minutes. Anything else?
Yeah, I'd like to ask a follow-up question for Jack. Of the people, the 8 people, nobody's in court yet. I think the last time I talked to you, Jack, you said one person was hovering, maybe going that direction. But of the other 7 people, I guess my question is, how is the services being provided to them being funded? And how long have they been there? And how do you resolve the the source of the Board of Supervisors funding, which was for AOT? Well, I shouldn't say it that way. How much of what you're doing with the 8 people is screening, and how much is just straight provision of services that would potentially be sustainable for some period of time?
So I think, the 8 people that we've had, sometimes what happens too is there's referrals made to EA or even to us, and then we're just not able to locate the person. So that phenomenon happens sometimes. And then there's been a couple of folks that I think have ended up in a psych hospital, and maybe their decision was to go on to conservatorship rather than continue with AOT. There's been a couple that have ended up in jail where they were declared incompetent to stand trial. So at that point, they're sort of on this state hospital track or diversion track. And so we've had some outcomes like that. And so I do think that it depends on where they're at that process, Tim. I do know the therapists and the case manager are doing the outreach and engagement, for those that are in that spot where they're kind of deciding what they would like to do. And then some are engaged in treatment with ongoing services, including psychiatry. And so it really kind of depends on the client. The funding does come through, Medi-Cal billing, and then, the AOT funds through the general fund that we got from the Board of Supervisors. So that's kind of where largely the funding is happening. Did that answer your question?
Yeah, the only thing I'd add, we don't have a lot of time, maybe next time we could talk about it, but what's our burn rate on the general fund money that's coming from the Board of Supervisors? In other words, are we underspending what we thought we would do over time, or are we right on it or ahead?
Yeah. Yeah, that's part of our analysis that we're working on right now. And so sure, I can provide more detail coming up.
Great, thanks.
The question, Tim, and thank you, Jack. I'm going to adjourn the meeting and hope nobody gets a parking ticket.
Sorry.
And if they do, the county will pay for it.
Yes.
Thank you, everybody.
I want to.
We have to put in the reimbursement request.
Sounds okay.
I think that's what the county would call a gift of public funds.
Yeah, exactly. Thank you. Bye, everybody.
Bye.
Level that microphone, they shouldn't be able to pick up all. Okay, then they're taped up on the board. Yeah, I think we should.
New healthcare
Well, not-
education.
Yeah.
You aware of that?